Assalamu alaikum and welcome to the third session or scientific session of Pakistan Endocrine Society. This session is again going to be a master session as this session is very interesting and related to the master gland pituitary. So first of all, to chair this session, I would like to invite Dr. Shahid Ahmed. Dr. Shahid Ahmed is a consultant endocrinologist at Hearts International Hospital, Rawalpindi, and professor of medicine at Islamic International Medical College, Rawalpindi. His main interest is in pituitary disease, especially acromegaly. Now, I'd like to invite our second chairperson, Dr. Professor Dr. Asif Bashir. He is Tamgha Imtiaz. He is renowned neurosurgeon, has worked for 2 decades in the USA and is now leading neurosurgery in Lahore. He is the first ever neurosurgeon in Pakistan to implant vagus nerve stimulation for the treatment of epilepsy. I think sir is not available. So our third chair of the session is Dr. Hussain Afridi. He is Associate Professor, Diabetes and Endocrinology, Hayat Medical Complex, Peshawar. His special interest is in diabetes prevention. And our third chairperson is Dr. Waqas Shafiq. He is the consultant endocrinologist at Shaukat Khanam Memorial Cancer Hospital and Research Center, Lahore. Welcome, sir. So I welcome all the chairs for this interesting session. Now moving towards our first talk of the pituitary session. So our first talk will be on the neurocognitive complication of pituitary dysfunction. And for this, I would like to invite Dr. Ali Imran. He is the professor and chief of endocrinology, Dalhousie University, Canada. He is also director of neuropituitary and thyroid oncology, and his key research interests include neuroendocrine disorder and thyroid cancer.
Thank you again for very kindly inviting me here. In the next 20 minutes or so, I'm just going to take you rather rapidly through these learning objectives, which are to learn the lingering neuropsychological and neurocognitive dysfunction in patients with cellular masses, and the impact of these on their quality of life. Probably try to dissect the underlying pathophysiology and possible approach that we tend to use. So I'm going to start with a couple of patients. The first patient of mine was a young guy who presented with a large pituitary tumor on the top right-hand corner and basically had acromegaly. Diagnosis was confirmed, had surgery we have a very good neurosurgeon, and thankfully he went into remission. I'd never like to use the word cured because there is nothing like cure in these disorders. So he went into remission. He did require testosterone and thyroxine because of some pituitary dysfunction, and yet continued to complain of fatigue, sexual dysfunction, problems with relationships, and anhedonia, and started seeing a naturopath for this problem. Very, very frustrated, thinking he's got some chemical imbalances. And this is the second case of a 52-year-old female presented with incidental finding, which is a large pituitary mass, as you can see in the context of dizziness, had surgery because she had some vision problem. It's on thyroxine and started hormone replacement therapy. And the reason being that she went through menopause earlier, no problem, but as soon as she received her surgery and tumor was removed, she started having some of those quote-unquote symptoms of menopause, night sweat, sexual dysfunction, poor memory, sleep disorders, and she decided to go on HRT without much benefit, very frustrated. So this is what we see on a routine basis. There's no surprise, most cellular mass patients that I see in my clinic, and I have about 1,800 pituitary patients in my clinic that I follow, they do not feel normal even after surgery or surgical or biochemical remission of these patients. This slide tells you that cellular mass patients, or pituitary patients, they continue to have a higher mortality even after they have gone into remission. And on the right side, I'm trying to show you that they're more likely to take disability pensions and more likely to take sick days. So there is something going on that despite normalization of their hormones, there is something else that we need to deal with. So the question is, what are the key quality of life determinants? How does it impact your quality of life after remission? This is a paper that we published several years ago now, where we looked at acromegaly patients and compared them with a non-functioning pituitary adenoma cohort. And what we showed that acromegaly patients were more likely to have neurocognitive and psychological problems, particularly with their self-esteem. They had issues with their relationships and so on. And this is a paper that we just published last year in JCNM, essentially showing that acromegaly patients were more likely to have poor cognitive function, poor memory issues, sexual dysfunction, decreased quality of life, which was associated with depression and anxiety. So these are the patients who were controlled for many, many years, sometimes 10, 15 years after their remission. This is not just limited to acromegaly. If you look at Cushing's patient, this is the meta-analysis of your Cushing's patient, several studies essentially showing that after going into remission, after having surgery, Cushing's patients never achieve normal quality of life. They continue to feel unwell. And you keep telling them the same thing, that you're now quote unquote cured, but they just don't feel well. If you look at prolactinoma is very easy to treat. If you like, these are small tumors, you give them medical therapy, bromocriptine, cabergoline, whatever, and they feel great, fertility restored. But look at this particular slide, small group, female patients, and microprolactinoma treated with medical therapy. They still continue to have ongoing fatigue, ongoing memory issues, ongoing cognitive issues. So this is prolactinoma. And this is not just related to functioning pituitary tumors. If you were to look at non-functioning pituitary tumors, non-functioning adenomas, this was an interesting study basically comparing your acromegaly patients on this side, your normal healthy controls, and the non-functioning adenomas. And look at this circled area. Non-functioning pituitary adenomas continue to have poor cognitive function, poor psychological outcomes, and that is compared to healthy control. So this is not just related to functioning tumors, but also non-functioning tumors will continue to cause this problem. We just published this study last year, and I'm not going to take you through most of it, but this was interesting. For those of you who deal with the frail population, falling is one of the most sensitive markers for your cognitive function. Those people who have poor cognitive functions, Alzheimer's disease, they're more likely to fall. So we looked at the risk of fall in acromegaly patients. These are young patients. And what we found that the rate of fall was twice as high in both non-functioning patients and acromegaly patients compared with the general population. So clearly there is a problem going on. Now the question is, what is the underlying reason for all this? Well, these are the probable key players: hormonal dysfunction, mass effect of the tumor, surgery and radiation therapy, and then hormone replacement therapy. And I was listening to Professor Amir here, because some replacement therapies are simply not available in certain countries. Chronic disease being itself, chronic disease can also lead to these problems. Any chronic disease can do that, and other coexisting conditions which also happen in pituitary patients. So I'm going to tackle the first three together. And in essence, if you were to look at this particular cartoon, key areas of the brain which control your memory, which control your feelings, which control your emotions, which control all your neuropsychological function. Your pituitary hormone receptors are present in those areas, hippocampus, amygdala, you name it, and you have your hormone receptors. So they have a much more varied effect. Look at growth hormone, for instance. Growth hormones receptors are widely distributed in your CNS, and both low and high growth hormone can lead to effect on these receptors. I'm going to show you this very interesting study. If you look at this, I'll use this one. So in essence, if you look at this mouse, that's okay, don't worry. Thank you. If you look at this mouse, this was growth hormone deficient mouse after trauma, and you can see, look at the trail making test going from point A to point B. It has to go all around the place. But if you look at the same mouse after giving her growth hormone, you can see it starts recruiting these neurons, and look at this trail making. So a significant improvement with growth hormone in their cognitive behavior. Now, growth hormone deficiency is also associated with very poor sleep. If you don't have appropriate growth hormone, you won't sleep well, and poor sleep is going to impair your memory as well, which can be restored. We were just discussing yesterday, I think Professor Atul was mentioning, in patients with secondary hypothyroidism, we normally give them thyroxine, and we don't care if it is somewhere in the normal zone. That's not appropriate. You really need to keep your thyroid levels in the mid to high normal range where most of us reside. So in this particular study, they compared the effect of weight-based dosing, which is more accurate dosing, versus empirical dosing, where you just keep it somewhere in the normal range. And weight-based dosing was associated with better cognitive behavior. So undoubtedly, normalizing your hormones is absolutely crucial. In prolactinoma patients, those with those patients with prolactinoma, this was a Chinese study, very nice study. They looked at the gray matter volume, essentially showing that higher the level of prolactin, the more likely you're going to lose your gray matter volume, which is associated then with poor cognitive function. And this particular study, what they showed was that in patients with microprolactinomas, they used EEG for neural processing time, showing you a stimulus on the screen and time that it takes for you to respond to it, and showed that prolactinoma patients had a delayed neural processing time. In patients who are hypogonadal, who are treated with testosterone therapy, in this particular study, they treated the patient with testosterone. These hypogonadal men treated with testosterone to keep their testosterone levels normal. And despite that, these patients had poor trail-making tests. They had neurocognitive dysfunction. Look at the p-value. Significant neurocognitive dysfunction, significant anxiety and depression. So this is despite appropriately treating these patients. What about posterior pituitary hormones like vasopressin and oxytocin? We don't really bother with these patients. And look at this. Oxytocin is a very crucial hormone, and oxytocin is associated with your behavior, particularly in patients with schizophrenia, autism, and substance use disorder. So essentially, they are now doing a study looking at the role of vasopressin, for instance, in aggressive behavior in Huntington's disease patients. And the problem is that, unfortunately, we don't have oxytocin available. What about the lack of access to medical therapy, chronic disease, and other coexisting conditions? Well, this slide basically shows we normally give patients hydrocortisone replacement therapy twice or 3 times a day. But look at it, this is completely non-physiological. And if you look at the normal physiological hydrocortisone or cortisol release pattern, you have this levels are high in the morning, they tend to peter out in the day. Here you have 2-3 peaks in a day, which is completely non-physiological. And this particular study basically looked at dual release hydrocortisone, which tends to mimic your daily cortisol production. And what it showed that in patients who were given this treatment, they had much better improvement in their cognitive function, well-being, and fatigue. So physiological replacement therapy is absolutely crucial. I think that's the point I'm trying to make here. Testosterone therapy, I don't know what is available in Pakistan, but in Canada, for instance, we have injection, which is cheaper, every 2 to 3 weeks, or a cream which you apply on the skin. So injection, as soon as you give the injection, your testosterone level will rise to supraphysiologic levels within the next few days, and then it peters out and drops to below the normal range, completely non-physiological. And growth hormone, the price is just absolutely horrendous. It's about $1,200 to $1,500 a month in Canada. It's not covered in some provinces, so patients have to dish out that money or get private insurance. So again, it's a problem for us when we replace growth hormone in these patients. And as I mentioned, prolactin, oxytocin, etc., they're not even available. So in summary, these affects neurocognitive problems associated with pituitary. They tend to be multifactorial. I think I showed you a number of possible reasons. Several of these factors are outside our control. I mean, we can't do anything with the receptors in the brain where they are situated. And also appropriate replacement therapies are not always available. And we need to look at this area, because unless we do that, we look at the holistic approach, take a holistic approach to these patients, they're not going to feel better. You're going to tell them that your hormones are fantastic, I've replaced you, but they're not going to feel better. They're not going to thank you for what you have done. So what's the way forward? I think we really need to recognize this. We need to listen to our patients. We need to as a group, look at better hormone replacement, better coverages, try using testosterone gel as opposed to, if available, growth hormone, at least try to keep the thyroid hormone levels in a normal range. And we need to move away from biochemical centric control of these patients to more of a multidimensional disease activity tool. Ask the patient about how they feel. And one of my, and the colleague before me was talking about cognitive behavior therapy. Fantastic opportunity. I'm just going to show you a slide. This particular slide is from, they use CBT in patients with acromegaly. Essentially, it means seeking help from your psychology colleagues. And what they do is that, changing negative thoughts into more positive thoughts. It just amazingly, it works. And I initially thought this was absolutely hocus pocus until I began seeing the effect on the patients. It's absolutely amazing how changing your thought process makes you feel. So in my patients, all I did, I had a long and frank discussion with both patients, and I showed them that, look, I understand why you are feeling this way, and there is a problem, and this is the reason why you're feeling. And I said, would you be willing to go to psychological counseling? And both of them declined. But amazingly, they came back to me next time and they said, just the fact that you understood it made us feel better, that this is not something that we were just brushing under the carpet. So patients need to be heard and understood, and educate them about the lack of evidence regarding many alternative hormonal therapies. So in my case, in my patient's case, they were going to naturopath and herbal supplements. So I told them, it's not going to help. It won't help. So try to have a chat with your patient, and just absolutely amazing how it helps. Those of you who are interested in doing some more reading, there's a paper we published which just came out. It's a cognition, psychological well-being, and hyperpituitary patients. Have a look at this. Here I have summarized all the basic science and other things that are currently available. And thank you very much. I'm sorry I rushed through it because there was a lot of data to share in 20 minutes, always a bit difficult. But I hope I haven't turned any one of you off from this topic. Thank you again. Have a nice day.